Hi everyone, this is our dashboard project. We have four members in this team. We are going to talk about medication errors in healthcare, and now I'm going to talk about dashboard. So a dashboard is a condition-specific, actionable web-based application for quality reporting and the population management that is integrated into the electronic health record. Quality indicators are standardized evidence-based measures of healthcare quality that can be used in running a variable hospital inpatient administrative data to measure and then track clinical performance and the outcome. Nurse and the managers described that the care utilized evidence dashboard was a vision tool that display data on the impact of the nurse care provided to a patient. A semi-structured interview topic guide was developed by the research team to collect the data for the dashboard. And in individual indicator using assigned the indicator on dashboard. The study was carried out for 2 years with an overall of eight quarters. A quarter is 30 patients in ICU. 8 quarters in 2 years period. Sample size is 1,440. Nursing care quality data can be accurately and reliably abstracted from the electronic health record of intensive care unit patient using a well-developed data collection tool and detailed training. Testing of this indicator use automate data extraction would facilitate future practice-based patient-focused research in ICU setting. CMS and the reimbursement is issues because CNC is no longer reimbursing hospital for some hospital acquired conditions and the safety event measured by QIS.
My name is Hawa, and I will be doing this next slide on investigating the problem, which is medication error. The five most common causes of medication error, according to Chu study in 2016, are distraction, fatigue, increased workloads, miscalculation, and deficit in pharmacologic knowledge. And these are just some of the noted common error. According to Chu's study, the nurses who do not follow the 5 rights of medication administration contribute to medication error. When there is a lack of adequate staffing, it increases the workload and causes fatigue. Then it predisposes the nurse to take shortcuts where that nurse then fails to follow the drug protocol or the administration to follow those 5 rights. And according to the study by Chu, a large percentage of error is based on distraction. When the nurse is both distracted and physically exhausted, the risk of drug dose miscalculation increases. So, why is it important for staff awareness and the need to address medication error. According to a study by Mohanty in 2016, medication error is the third most leading cause of death in the US. 440,000 patients die every year from avoidable medical error. Each patient is vulnerable to at least one medication error every day. And I think if we can put ourselves in the role of both sides to think about the role of that nurse who makes the error, or putting yourself in the role of the patient who will be the victim to receive that error, it helps to see the gravity of the issue. It is not only costly to the hospital or the institution where it happens, but it's costly to lives, it's costly to careers, and so many other things in society. This study by Mohanty in 2016, the research um, the researchers states that nurses are the backbone of patient care, as they are directly involved in activities related to patient care. So nurses are well positioned to as compared to other care providers to detect, report, and prevent medication error. And they go on to say that a prompt continuous nursing program and awareness program are a mandate to decrease the medication error. So that's what makes it very important for staff awareness in addressing this deficit. This next slide is addressing medication error to improve performance. 5 evidence-based best practice interventions that address a medication error by Rajevich et al. In 2020 are barcoding systems, standardized units of measure, avoiding confusing units of measure, weight-based dosing, having a pharmacist available to assist with calculating the correct dose. A couple of um, current best practices that are implemented in the U.S. hospitals are listed as following in my next bullet point here. And they come from the ISMP, which is Institute for Safe Medication Practices. Is a watchdog on medication error and prevention. And these practices are the dispense vincristine in a mini bag of a compatible solution and not in a syringe. In the past, deaths have been reported throughout the world when the drug was dispensed in a syringe and given into spinal fluid instead of intravenously. Now, many organizations have successfully switched to preparing vinca alkaloid in mini bags, including pediatric hospitals and health systems, overcoming concerns of extravasation and other complications. There have been no reported case of accidental administration of a vinca alkaloid by the intrathecal route when dispensed in a mini bag. And the next one is the way to weigh each patient as soon as possible on admission and during each appropriate outpatient or emergency department encounter. Avoid the use of stated, estimated, or historical weight. And then you should have a metric scale available in all areas where patients are admitted or encountered. Ensure that the metric weight is documented in the medical record. Do not rely on a patient's stated weight or a healthcare provider's estimated weight or a documented weight from a previous encounter. This ensures that the patient's actual weight is obtained upon admission or appropriate encounter. Many medication doses are based on the patient's weight, and relying on a stated, estimated, or historical weight can cause inaccurate dosing, both under and overdosing. And now the data that the graph that is on the right hand side, right corner by Leah or and from 2018 is just something that points out how implementing safety measures have actually lowered medication errors. This was done from 2008 all the way to 2016, and there was a very good decrease that was seen, as we can see on the graph, from errors that were about 7 per every 10,000 case to about 2.2 to every 10,000 case since 2012.
My name is Kaylee Kesterson, and I'll be going over these next two slides. The first slide I'm going to go over is application of monitoring quality indicators to the EHR client. So there are settings in the EHR that facilitate the process related to quality improvement and data collection. The process is described in the article that I chose here called Developing Electronic Health Record Strategies Related to Health Center Patients' Social Determinants of Health. Is a first phase of a pilot study designed to develop EHR-based tools that clinics could use to systematically identify and act on their patients' social determinants of health-related needs, which are also called SDH data tools. So SDHs are non-clinical factors that profoundly affect health, like smoking, alcohol use, stress, etc. So the EHR facilitates this process with data tools that are built in that can collect information, so researchers in this case are able to create SDH-related workflows that parallel clinical referral processes. This happens by addressing patients' needs in 5 key steps. So they collect the data, they review the patient's SDH-related needs, they identify referral options to address those needs, and then they order referrals to appropriate services, and they track the outcomes of past referrals. And this is just one example of how the EHR can collect patient data and the use of this data for quality improvement. So in the literature, there are programs like BCMA, POE, and CDSS in the role of data collection in the EHR. So Barcode Medication Administration, or BCMA, works at the patient's bedside. Nurses scan their badges or log into the BCMA system, scan the patient's wristband, and scan the medication. The BCMA system validates whether the 5 rights of medication administration, right patient, right drug, right dose, right frequency, and right route, match the order entered in the CPOE system. If there's a discrepancy, an alert is displayed on the computer screen. Once a medication is scanned, it is automatically documented in the MAR as having been administered to the patient. So POE programs were created with the cessation of medication errors in mind. POE, or Provider Order Entry, computerizes orders for patients that are the connective tissue in any EHR. So they are necessarily complex because they integrate patient-specific interventions across departments. Orders are written by members of the healthcare team, primarily physicians and nurses, and they are put in that system and they can be accessed in the EHR. So CDSS, or Clinical Direct Decision Support for Nursing, it guides nurses in identifying patient preferences to improve the degree that nurses are able to act in accordance with patient preferences. The role of the BSN prepared nurse in facilitating the change to improve quality is the use of their formal education of systems thinking for error prevention. So the BSN nurse is required to take extra courses and use critical thinking skills in their undergraduate degree that other registered nurses programs do not require. So part of the solution on how change can occur when talking about medication error is to maintain a culture that works toward recognizing safety challenges and implementing viable solutions rather than harboring a culture of blame, shame, and punishment. Healthcare organizations need to establish a culture of safety that focuses on system improvement by viewing medical errors as challenges that they need to overcome. All individuals on the healthcare team have to play a role in making the provision of healthcare safer for patients and healthcare workers. So education for staff and maintaining an environment where medication errors can be a learning experience is important because healthcare professionals experience profound psychological effects such as anger, guilt, inadequacy, depression, and even suicide due to real or perceived errors. This can cause or it can lead to a loss of clinical confidence. Clinicians equate errors with failure, which is a breach of public trust, and with harming patients despite what they said that they would do, which is to not do any harm. Fear of punishment makes healthcare professionals reluctant to report these errors because while they fear for the patient's safety, they also fear for disciplinary action, including the fear of losing their jobs if they report an incident. Unfortunately, failing to report contributes to the likelihood of serious patient harm, and many healthcare institutions have policies in place that can cause staff to hesitate to report an error. They can minimize the problem or even fail to document the issue. These actions, or lack thereof, can contribute to the evolving cycle of medical errors. So the last thing I want to talk about is nurse monitoring. And this is a repeated, regular, and ongoing process conducted by multiple nurses as they monitor their patient's condition around the clock. So everyone goes in and they have hours that they have to round and monitor the patient's vitals, which this can prevent serious complications, adverse events, medical errors, and death. So patients frequently exhibit physiological signs of instability in the respiratory, cardiovascular, and neurological systems, which is measured in routine monitoring. While nurses are routinely collecting vitals, if anything is out of the normal limits, then it alerts the EWS, or early warning system, which reminds the nurse that these values are abnormal, and this can then trigger an RRTS, or a rapid response team. And a rapid response team consists of a group of clinicians who can be deployed at any time to bring critical care expertise to patients at any hospital location, ensuring timely delivery of appropriate treatment and prevention of patient deterioration. The RN can assess the effectiveness of these systems and whether they are positive or negative, and I would say that most of them would say that they are positive because it's really helpful to have these systems in place so that human error can be intervened with system interference.
The role of informatics and its implication from the Journal of the American Medical Informatics is one of the most essential yet underemphasized aspects of the informatics curriculum across the country. Decision support for medication prescription and dispensing has always been one of the most direct ways for information systems to promote patient safety. An informatics implication would be not having a standardization of terminologies, ontologies, and foundational research in natural language processing and information retrieval. But a solution proposed was having a possible use of EHR-based clinician text notes to validate. Since the goal of informatics in medication error reduction is to improve patient safety and clinical outcome by reducing the risk of accidents that occur due to medication error, we see informatics usage when a quick verification of another RN nurse is made before medication administration. This conclusion was made after 4 errors were rectified before IV medications were given in a 24-plan Do Study Act ramp conducted by Rajiv and his partners in a Quality Improvement Initiative study. Data mining is relevant to a medication error. It has been widely used to analyze medication error reports and improve patient safety by utilizing advanced computational technologies, including natural language processing, statistical analytics, and machine learning algorithms that can transform biomedical data into meaningful knowledge to improve patient safety. From all that I've learned so far about informatics and its importance, using the EHR would be my first recommendation. I think it would reduce medication error significantly by efficiently chatting patients' information by using a universal language every nurse understands. On the other hand, it would reduce the hazards of miscommunication. Verifying with another RN nurse is also an excellent idea for medication error prevention. The role of performance measures in medication error evaluates whether if the elements being measured with current instruments are related to the results gotten. Tools that are used to measure medication error are compared with the results achieved. It also provides information about content validity. When looking at the statistical results and the method used, the difference between the changes made is evaluated. Performance deficit, like performance measures, is an instrumental tool to assess for progression. Therefore, performance deficit is vital to track or follow up onset measures to see if progress is achieved or made. It helps to understand if the strategies laid out to perform a specific goal are the best option or if something else needs to be tried. Medication errors are widespread throughout the medication use process. A small proportion of error could cause clinically significant adverse drug events. Constant vigilance, review, improved communication with other healthcare practitioners and patients may reduce errors. Medication error poses detrimental effects financially in a hospital. Accidental waste is an example because some medications may worth so much and making an error during its administration would be no fun. A family could sue a physician or the hospital, which could put it into a lifelong debt or even make the physician in question forfeit their license.